Hello, everyone. We're happy to see you today. Happy you made it to our last coalition meeting of the year. So if you want to go ahead and put your name, organization, and what county you are in the chat, that would be great. And if you're able to leave your camera on, we would love to see your smiling faces. If not, we understand. You know, it's a busy time of year. People are probably driving some, but we're happy you made it. Hey, Amy's on here. Hey, Amy, great to see you. Marshall University, Dietetics Department. So glad you're here with us. Adam, glad he made it. Many Hamilton Health System is here. Happy to have Health System. American Cancer Society. Glad Evan Worrell's on here with the West Virginia House of Delegates. Thank you for putting your names in the chat. So name, organization, and county, if you remember. And Lacey, our rock star from the Department of Ag. Love what she does. Jim Smallridge is here. Jeff Tanner from Roan General Hospital. Happy to have you. It's 50 people. It's a lot of people today. Are we good to go to the next slide, Ryan? Are we still have people coming in?
Yeah, it looks like the waiting room is slowing down, so I think we're ready.
Okay. Perfect. All right, well, we're going to get started. So we did an exciting thing. So we finalized our vision and mission statement. So that is on the screen. I'll let you guys read it, but this is our final vision and mission of our coalition. So we're excited about that. And we did update our one-pager and our website to reflect the changes that we made to the vision and mission statement. And yeah, Ryan just dropped our one-pager in the chat as well. All right, and then I'm just going to review the agenda. So we're going to recap from our in-person meeting that we had in September. Thank you for all of those that joined us. It was a wonderful meeting. We are going to provide some updates about what our coalition has been up to since the in-person meeting. And we have Kristen and Cordell who are going to be presenting today on policy levers for expanding access to food as medicine services in West Virginia. And then we'll wrap up and talk about the next steps. So again, we're very happy that everyone is here today. And I am going to turn it over to Dr. Greco. She's going to actually share some recaps from our in-person meeting at Stonewall.
Yeah, we wanted to say thank you to all those people who attended our first West Virginia Food as Medicine Coalition in-person meeting. We have here, as you can see, an official list of 53 agencies and groups who attended. We had a tremendous turnout for this meeting. So take a quick look. They're in alphabetical order. If you can't find your group on here, let us know and throw it in the chat. But again, we had a tremendous attendance for this meeting. We also had overwhelmingly positive feedback about the meeting from everybody who attended. As you can see, participants said that they made at least one new connection and they learned about new programs at this meeting. They felt that the West Virginia Food as Medicine Coalition could help them to advance their own goals, and that they would be happy to attend future in-person meetings for the coalition. Attendees appreciated the small group breakouts, the networking opportunities, the lived experience stories that we presented, and of course the great policy and Medicaid lecture that was presented by Kristen Sukes. Attendees also mentioned that there was a lot of energy in the room, there was a lot of energy in the presenters, and motivation of the presenters. So that was great. And also, as well, of course, the beautiful venue we had and the great food, not to mention the gorgeous weather we also had. I personally enjoyed meeting so many people that I don't really know via Zoom for the last 4 or 5 years since COVID and all that happened. So it was great to actually meet people in person and give hugs and all that good stuff. Anybody else want to chime in for reflections?
I would say that I left that conference feeling the momentum, and it has carried me over recent weeks. Just that there's a lot of not just the energy, but the tangible work that's being done and the partnerships that were already there. Just the fortifying those relationships to move forward as a coalition, and the pieces that have been in the background for this coalition, learning about what all you have been doing to make this a statewide effort. Just a lot of encouragement, and continuing to learn more about what is happening for us here.
Anybody else want to come off mute, chime in? If not, we can move right along. Next slide.
Okay, so we're going to turn it over to Gina to actually discuss recent developments that the coalition has been up to. So I'm going to turn it over to Gina.
Yeah, thanks, Miranda, and thanks, Dr. Carroll. So for those of you who I haven't had the pleasure of meeting before, I'm Gina Wood. I'm a extension specialist with West Virginia University Family Nutrition Program. It's great to be here, great to be with all of you, and thank you so much for joining. Just want to start our updates with the Rural Health Transformation Program. Governor Morrisey recently requested the public's input on some of the priorities that folks felt West Virginia should address through the program. We were able to submit a plan on behalf of the coalition to build some infrastructure and systems that would be necessary to support the scalability and sustainability of food as medicine interventions on a statewide level. So a little bit about the timeline for those applications. Each state has to submit their application by November 5th. Notification of award is expected by December 31st. And if you want to learn more about this particular opportunity, you can check out the links on the slide to the state page and also the national state tracker page. We also recently received a request to meet with our Department of Health Secretary, Dr. Arvind Singh, who was interested in learning more about food as medicine. He wanted to learn more about the coalition as he was preparing for an upcoming meeting that he has to attend in Washington, D.C. We're happy to report that meeting seemed to go very well. And we're also scheduled to meet with our Department of Human Services Secretary, Alex Mayer, in mid-November. So we are especially grateful for their interest in food as medicine. They have some really good questions and really want to learn more. So we're super grateful for them. In terms of our ongoing efforts, we want to complete, or we plan to complete, another food as medicine environmental scan for 2025. And we're starting now to build out the survey that will facilitate the data collection for that report. So I do want to take a minute to pause here and ask if anyone has input on any information that they might like to see included as part of that report. If anybody wants to come off mute and share your thoughts, that would be great. If you're feeling particularly shy, you can also type your thoughts in the chat or even email us with your ideas. So we did share a copy of the 2024 environmental scan at the in-person meeting. That's also available on the resources tab of our website. But it's time now to do one for 2025. So would love to hear thoughts, ideas, anything at all that you'd be interested in seeing in that report. Do I have to pick on?
It looks like Bree's raising her hand.
Is Bree raising her hand? Oh, great. Bree, please share your thoughts with us.
Hi, Gina. Thank you. So as an area health education center, I'm particularly interested in what the staffing and workforce needs are in order to support different food as medicine programs across the state. So, types of positions, even like percent time or FTE, things like that would be incredibly helpful to us from a workforce development perspective.
Yeah, that's fantastic. I love that idea. We have done some informal collection of that data for some of the programs that, us as individuals have been working with. We know that implementation of food as medicine programs is really time and labor intensive in a lot of cases. So that is a wonderful, wonderful idea. Thank you for that, Bree. Really appreciate it. Does anyone else have thoughts? And you don't have to say them now if you don't want to. If you want to take some time to think about it, please feel free to shoot us an email. And again, please type in the chat if there are things that you think about throughout the course of the meeting. But we appreciate all of your thoughts, all of your input. So we are also still recruiting members to join the coalition, and we want everyone to feel welcome. This coalition is open to anyone at all, anyone and everyone. So please help us spread the word, especially if you feel that there might be sectors that are or underrepresented in the current list of members that Dr. Carroll showed earlier. We do have a registration form on our website and a link to that form on the slide here as well. Check out our website if you haven't done so already. We're adding new tools and resources pretty frequently, so please visit. And we also now have an email address, so as an additional way to get in touch with us. So if you feel like dropping us an email with any thoughts or concerns, please reach out to us at wvfimcoalition@gmail.com. We'd love to hear from you anytime at all. So in terms of events, we want to remind folks that the Food for All Policy Summit is coming up on November 14th in Morgantown. It's being held at the Erickson Alumni Center on the WVU campus. The food policy landscape, as we know, is really changing very rapidly at the state level, at the national level, and sometimes it's difficult to keep up. But this is an event that is a great way to stay current, interact with experts in food policy and meet others who are working in that space or even just interested in food policy in general. There isn't a cost to attend the summit. It's free of charge. The registration link is on the slide, and the events tab of our website also has event and registration information. So Ryan, if you want to just shift over to the next slide. No one, the folks from Facing Hunger weren't able to join us today, but they did want me to share the news with you that they have been awarded a $437,000 grant from CVS Health and Feeding America. So huge congratulations to them. These funds will help establish and test some systems to meet the needs of food as medicine partners, which includes streamlining some of the administrative processes for food as medicine interventions so that healthcare providers can continue to do what they do best, which is focus on taking care of the people that they serve. Some of the partners who will be involved in the initial phases of this 2-year award are listed here. This list is not exhaustive, but the first deliverable is to conduct a landscape assessment within the first 3 months of the grant, and then facilitate activities that are related to the core functions of the grant, which are health policy advocacy, establishing points of contact with providers and payers, coordinating regional implementation, and capacity building. So I'm sure we'll be sharing more with you as this work unfolds. So we're excited about it and want to congratulate Facing Hunger on on that award. So those are all the updates I had to share today. So I'm just going to turn it back over to Cordell Bostick and Kristen Sukes, who are going to lead our policy discussion this afternoon.
Thanks, Gina. We breezed through that intro and updates, which is great for me because my section was a little tight. But before I kind of jump into these policy levers here, I'm just curious. So the environment, I want to refocus on the environmental scan. This is such a great opportunity to figure out what is going on with food as medicine in the state of West Virginia, across many different kind of categories. And so, we can definitely look into what programs are operating in the state and like the specifics around those programs, like how many people are they serving? Are they seasonal? Are they not? Are they contracted with healthcare providers or not? All of the program stuff we can definitely take care of. But I'm also curious, I mentioned in the chat, we had Bree that mentioned like, well, what is like the workforce that supports food as medicine? I think that's a great question. And often there, not only like dietitians and nutritionists, but community health workers tend to be like a really critical component of the care team for food as medicine. So we can definitely ask about that. I'm personally interested in like the provider knowledge of food as medicine and like what's the appetite for increasing access to these services for like the leaders of managed care plans or other like private health insurance. So I'm really curious about like insurance-based opinions. But I'm curious if folks just have like two more kind of questions or wonderings that they want to add, because there's so many things that we can look into that I think would help inform a broader strategy in West Virginia. And we're going to start kind of like mapping out our goals for this environmental scan. And so we're really wanting to like figure out what are the most important questions that we can answer for you all. So yeah, provider knowledge. Thanks, Danielle. Oh, definitely funding. How are food as medicine programs funded? I would also say, what are the perspectives of the funders in the state too? Maybe. I'm looking for one more question before I move on to policy. Like, tell us what you want to know. All right, well, we'll let you off the hook this time, but we will be asking you all again as we start to kind of map out what this project looks like, because it's going to be a pretty large project. Okay, policy. So, there's 63 folks on this call. I'm assuming that a lot of you were at the in-person meeting. So I am going to be going over some of the policy information that I shared in the meeting. But, according to feedback, this was really helpful information, and repetition is really key, especially for these types of policies, and health policy in general can be quite complex. Okay, great. So next slide, please, Ryan. So some of these, this is definitely a reference slide for you all. I think it's just good to always take a moment and kind of look at the trajectory of how policy has been changing over time. And this is a lot to go into. I also shared this at the event, but this is here for you all to reference, to use in your slide decks. If there's things on here that you have questions about, please let us know, and we're happy to talk further about them. So next slide, please. And then another recap, when I talk about policy, there's many different types of policy here that like impacts the access to food as medicine programs. So at the very top, we have like the most formal policy changes. That's like formal laws. We're talking budget, it's legislation, um, like anything that's creating programs and creating specifics around, what those programs have to do. But then underneath that, we have all the regulations and the guidance that are mapped out to support those programs, exactly how those things are being implemented. And that second layer is a little bit more nimble than, of course, the formal law and budgets. But then we have a lot of like organizational level decision making that happens at administrative policy too. Even like kind of like letters that maybe a state agency is sending out just for information bulletins, etc., stuff like that. But then even like inside, in our space, inside like managed care programs or inside clinics, they have their own policies that also dictate how folks get access to these services. So those are often just as important and sometimes even more important to look at than formal policy change because there's a lot more opportunity to change those things. And then, of course, we have programmatic policies and practices, and then cultural and contextual influences. So, how are we framing food as medicine across the state of West Virginia? How are people talking about food as medicine? Like, what's the gut reaction? We know there's a really big interest in an awareness of how food and nutrition impact health and of course impact like state budgets right now. But we want to kind of continue to like feed that and like our hope is to be a pretty big influence in the state and influence how are we talking about nutrition and healthcare. So we have to do a lot of thinking about that, and that's also policy. And policy is all communications, of course. So next slide, please. So there's a lot of different ways that we can kind of go about increasing access to food as medicine programs. And on the left, we have a bunch of federal programs. This is, of course, just in the health policy space and health insurance. But on the federal side, we have Medicare Advantage. That's like the private insurance companies that provide Medicare services. And so there are specific federal policies that kind of dictate what those insurance providers can provide in the food as medicine space. So that's like federal policy change. Also at the federal level, we have kind of non-healthcare policy things that happen as well. And things that are like maybe outside traditional Medicaid and Medicare, such as the Indian Health Services. We have the Veterans Affairs or Veterans Administration. We have the GusNet program through USDA, and there's various other like grants and funding sources, like HRSA, which I always forget the Health Resources Services, and I always forget the acronym of HRSA, but there's a lot of grants that we have to leverage to increase access to food as medicine through the federal lens. On the state side, though, and this for the state side, I'm focusing specifically on state Medicaid programs because that's where we have the most control. And there's a lot of crossover for the population of interest. We have low income individuals, within a system that we have a lot of say over at the state level. So it's a pretty good place for us to focus. There are a few different ways that states can alter their Medicaid programs, and those changes are done through Medicaid waivers, where they waive federal requirements to kind of like alter their Medicaid programs. So there's a couple different waivers that I have listed here, and that is a discussion for another time. So we don't have to worry about that as much right now, but it's something to be aware of because we are going to continue to kind of flex our policy muscles, for all of you and make you into these like really sound policy wonks, feeling really confident in this area. So take the waivers, put it over there for the moment. But I also introduced Medicaid managed care at the in-person convening. And I have a diagram on the next slide, which will kind of map out what this system really means. But for managed care, it's essentially the state has their own Medicaid policies. And normally, the traditional way of navigating Medicaid in a state is that the state takes all the ownership. They manage all the providers that provide care. They do all the contracting with those providers. They pay the providers per the services that they're providing. They organize all of it and coordinate all of it. But because we have a lot of folks that are entering the Medicaid system, especially with the expansion of Medicaid in states, it's really burdensome for the state to manage. So now they are outsourcing to third parties to provide that coordination support. And with that, by outsourcing, we have additional layers of contracting and additional layers of requirements and additional layers of flexibility. So there's a couple different pockets of flexibility that are very specific to Medicaid managed care that are really advantageous to us with Food is Medicine. And then, of course, across everything, and I've mentioned some of these at the federal level, but there's always so many grants and funding sources and pilot projects that can be done. So there's always these kind of like niche areas we can go in to find very specific time-limited opportunities to support Food is Medicine. So bump me over. Yeah, thank you, Health Resources Services Administration. Thank you, Mark. So for Ryan, I think I have an animation. So want to hit that again? Okay, great. Okay, Medicaid, we talked about kind of why we're focusing on it. But over on the right side, we see the difference between traditional Medicaid, where the state coordinates everything. That's a fee-for-service type of system. That means the state pays a doctor for a annual physical exam. Service per payment, fee for service. And on the right-hand side, you have the state, which contracts with a third party called a managed care plan. And that managed care plan then contracts with healthcare providers. And as I mentioned, in this system on the right side, there's a lot of additional flexibility. And we will go into kind of the layers of that flexibility and the details in another presentation, but just wanting to kind of repeat this information so we get core concepts kind of understood. So bring me on to the next slide, Ryan. Actually, I'm going to pause here. You can bring me back for a second. I'm doing okay on my presentation time because I'm breezing through what I've already gone over in the in-person gathering, but I also know this is a lot of information. So I want to pause for just a few minutes here and see if there are questions around this system. Another way to go about this, because there's a lot of people on the call, if this feels overwhelming, please put a number 1 in the chat. And if this feels like, okay, I think I'm kind of getting the basics here, put a 5 in the chat. Okay, we're doing pretty good. This is great. You guys are rock stars. Cool. Yes, and you can put numbers in between too. All right. So Ryan, bring me to the next slide then. And if anyone does have questions, you can just throw your hand up and jump in. So just an overview, most states they operate both systems of Medicaid at the same time. Certain populations are in a fee-for-service system, and certain populations are in a Medicaid managed care system. So, and sometimes states can operate many different Medicaid managed care systems. It might be broken up by population. And that's kind of how West Virginia does it. So the biggest Medicaid managed care program that West Virginia operates is called Mountain Health Trust. That's like what most of the Medicaid population is in. And there are 4 managed care plans that provide services within that managed care system. Then you have the fee for service. On the right side, you'll see there's about 18% of West Virginia's Medicaid population that's in a fee for service system. So, and those are generally like very specific services and populations. Folks that might have to have long-term care or be in nursing homes or long-term care settings. Some family planning services are in fee for service. But then also another type of managed care plan that the state operates is specifically for children that are in foster care or kinship care or adoptive care. And that is called the Mountain Health Promise. So you can, this kind of different populations can be put in different managed care plans because each plan has a specific set of services that might be the most appropriate for that particular population. Okay. And everything on the right is Mountain Health Trust, but I actually I think I did my colors wrong. Oh no, Highmark is green too. Yeah, so everything in the green is Mountain Health Trust. Okay, Ryan, bring me on. All right, I think this is my last recap slide. Actually, it's not, but we're almost to a bit of an interactive part. So we have formal policy, like very binding agreements. These are waivers that the states write out and have to be approved by the federal government. And these are also state and managed care contracts. So at the state level, we have the state plan and the state plan amendments. That's like your core document that outlines the basics of a state's Medicaid program. When you look at a Medicaid state plan, sometimes those documents are like really old, like they're scanned in, Xeroxed in. They can be from the 80s, the 90s, even earlier. Also, we have 1115 waivers. Those are really large demonstration projects, usually about 5 years. A lot of states have 1115 waivers. They've gotten a lot of attention in the press recently and at the policy level, especially in food as medicine, because for the last few years, states have been leveraging these waivers to cover food as medicine services. In West Virginia, we have a substance use disorder waiver, and currently that waiver does not cover nutrition services. And states at the moment are currently not thinking about 1115 waivers as the best path to cover food as medicine services because the federal government has put a pause on them for now. But that is something that I believe will come back, especially if there's a change of administration. 1915 waivers, there's a few different types of these. These essentially are waivers that provide services to people in their homes that keep them out of institutionalized care. So you can imagine that meal delivery services would be really critical to this. And so sometimes states use 1115 waivers to provide nutrition services that keep people in their homes instead of being institutionalized. And then, of course, we have the state and managed care or managed care organization or managed care plan contracts. It's your lucky day because we're actually going to learn what these look like together today and have you do some searching in them. And then for organizational and implementational policy, the managed care organizations or managed care plans themselves have a lot of discretion on the types of things they fund, the types of services they get access to. And then the states every year write up these quality strategies for Medicaid managed care that says, like, these managed care plans are going to be judged or graded based on XYZ. Some of those things could be related to health-related social needs or even related to food insecurity. So there's flexibility there as well. But these are kind of more incentive structures. All right, Ryan. So in West Virginia, there are a few upcoming policy changes that we need to be aware of. The first is that every year, managed care contracts are updated. They're typically updated in June because the managed care contracts themselves run in the fiscal year, so July to July. And so this past June, they released the contract for fiscal year 2026, which is the one that we're going to look at together in a moment here. Within those contracts, again, they outline all the requirements for managed care plans, and there's a lot of opportunity to strengthen requirements that push managed care plans to address food insecurity, screen for food insecurity, contract or partner with community-based organizations, etc. All things that support food as medicine. Then we have the managed care flexibilities themselves, where the managed care plans or managed care organizations on my slide are policymakers. This information can and generally has to sit somewhere in the managed care contract, but a lot of the information will generally be presented in like state guidance. So the Bureau of Medicaid Services in West Virginia would probably release guidance that tells managed care plans how to provide additional services, which the two categories for that are in lieu of services, which is where managed care plans can provide a produce prescription in lieu of future required diabetes management. You're allowed to do a service now that replaces a future need for a service. So there's a lot of flexibility here. And the state provides money for those services. So that is the best pathway for us because managed care plans get money for those. Whereas value-added services, these are additional services that managed care plans choose to offer, but they have to pay for themselves. There's still a financial advantage that's kind of a little bit wonky, but they have to pay for it, which means there's an additional barrier for them to provide it. Then we have the managed care quality strategy, and we have additional opportunities for legislation, but that's here for reference. I talked about it in person, can talk about it later, but I want to save some time for us to kind of dive into these policy documents together. So next slide, Ryan. Okay. Can folks access, if you can access the document that I put in the chat, please put a 1 in the chat. Okay, great. So when you open this document, this is West Virginia's Medicaid managed care contract. Put a 3 in the chat if this is your first time ever looking at this document. This is awesome. This is great. We're getting in there together. They're big. It's a big document. How many pages is it? It is 257 pages. So that is pretty substantial. But because I know how to navigate, and I'm going to teach you how to navigate these very large documents to get together today, there's an easy way to kind of like figure out the sections of the document where we might find clues around food as medicine. So in these documents, so there's a bunch of search terms that I typically use to look through these documents, and there's a ton of other variations, but today these are enough. I want you to control F for value-added services in the document. And when somebody gets there, I want you to type in the chat what page. Um, there's probably actually multiple value-added services pages. So I want you all to go down. It's 15, but if you keep going to page 124, when you're on page 124, that is the section of the contract that outlines value-added services. So if you read through this section, you can, it says that managed care plans are allowed to offer value-added services, but that they have to pay for them themselves, and the state, the Bureau of Medicaid Services, has to approve of them. And there's also specific requirements on how they plan to alert their members about these extra services. So I have you all search for value-added services because there are some states across the country where they might list typical value-added services in their managed care contracts that say plans can offer produce prescriptions as a value-added service. That's your choice. You can offer it. Plans can offer various things like smoking cessation programs as a value-added service, for example. These are services that are probably advantageous for the plan to offer, but and that's why like sometimes it's okay, they have to pay for them. I also want you to search for social determinants of health. And specifically, I want you all to go to page 126. On 126, you'll see that it outlines that every managed care plan needs to have a social determinants of health work plan. And it outlines kind of what needs to be in the social determinants of health work plan. The other acronym that you'll see in there, which is QAPI, that's the quality improvement plan. So that's the quality strategy that we were talking about. They also, if you keep scrolling, they have to do an assessment of social determinant of health needs. And they also have to have staff that's trained in social determinants of health case management. So these are pretty broad requirements. And, you know, one question that I would have for the environmental scan, depends on how detailed we're getting, but what do these plans look like? What does the staff training look like? Can we actually include education around food as medicine in these social determinants of health work plans? Can we include it in the staff training? These are opportunities that, you know, A, we could really try to change contract language to get more specific and have like nutrition requirements in there, but also B, we could just go to the managed care plans themselves and say, hey, what are you doing about social determinants of health? Your social determinant of health work plan. How can we insert nutrition and food as medicine in those things? So those are just a few. You can also, you know, if you want to have fun with these contracts, you know, go through these search terms. You'll also see about care coordination on how people are, you know, like, are they screened for food insecurity? If they're positive for food insecurity, what happens then? That's kind of interesting to look at. So take a look at those. I want to make sure I give Cordell a few minutes here. So Ryan, you want to move us forward? Great. So the other policy opportunity that I really want to leave you all with, and you saw a screenshot of the section of the contract on the last slide, is in lieu of services. These are those services that the state can provide money for, but the managed care plans have to kind of take the onus of providing. There's a lot of states out there. There's 10 states that actually leverage the in lieu of services pathway to provide access to food as medicine. There's a chart of them on the right-hand side. There was a wonderful paper that just came out recently that discusses how states are leveraging in lieu of services. I'll put the link in the chat after I'm done talking. But I wanted to call out 4 states that use this policy pathway in a pretty good way that we should maybe think about modeling our strategy after. One is Michigan. Michigan has really robust guidance around in lieu of services. They just implemented this like a year or two ago, and they have an entire website that's dedicated to it. And I am going to send this to you in the chat. Um, on that website, you'll find the final in lieu of services policy guide for Michigan, which is fantastic. That gives us a framework in that we can leverage in West Virginia. It's great. Also, Iowa. Iowa covers medically tailored meals, medically tailored and nutritionally appropriate produce prescriptions. This is interesting to call out because they cover food as medicine services, but for a very narrow population, which if West Virginia was looking to kind of test out providing broader access to food as medicine services, we might want to propose a pretty narrow population like Iowa did. These are very specific folks that are on a waiting list for, I think, institutional care, and they have specific conditions. So it's like pretty narrow. California covers a big spectrum of food as medicine services through in lieu of services. And then Minnesota does it a little bit interesting. They cover one in lieu of service or one type of food as medicine service per plan that has specific eligibility. It might be a condition, maybe people with just congestive heart failure. It might be an age range. It might be a disability. There's a lot of different ways to go about it. And we'll talk more about in lieu of services in like the coming months together. And then I think last slide, Ryan, and then I want to ping it over to Cordell. So of course, I talked about this slide too at the in-person convening, but West Virginia has a lot of maternal health initiatives, and we need to find out what the details of those initiatives are, and if there's a way to pair food as medicine services within those initiatives or have them be part of those initiatives. Additionally, Gina mentioned this already, but for federal grants, we have the Rural Health Transformation Program. A proposal was already submitted to the state, and of course, they're going to submit something by like November 4th, I think, or 3rd or 5th or something is the deadline. So we'll see what happens there. Maybe there's some support for food as medicine in that federal funding opportunity. Okay, without further ado, that was a lot to take in. Thank you for participating in my interactive policy exercise. And I'll ping it over to Cordell to talk a little bit about like the West Virginia landscape.
Hey everybody, my name is Quirrell Balsick with the West Virginia Food and Farm Coalition. I serve as the Legislative Policy Specialist. Kristen, thank you so much for that in-depth analysis of food as medicine. She is without a doubt the best food as medicine expert I've ever met. But I'm here just mainly to talk about those policy levers and how they're really pulled on the West Virginia landscape. So to get the state to do something, you have one of 3 ways to do it, really. The governor can do it, the legislature can do it, or the department itself can do it. Now, when you think of bills and rules and laws, you typically think the legislature, but there's a lot of flexibility within the 3. The governor has the ability to direct and mandate departments to do certain waivers. The legislature can request departments to give information and do certain things. But for this food as medicine initiative, one of the best angles I think we have available to us to really push this through is to work with the departments themselves with the assistance of the legislature and governor. So the department, specifically BMS, Bureau of Medical Services, they have the ability to create this in lieu of service waiver. They can send it up, it can be approved, and this could be a very direct way in which we can find funding for food as medicine. As Kristen was saying earlier, that we also have the contractual language that can be added into these MCO contracts. I know there's been a lot of excitement around food as medicine this past year in West Virginia between the First Lady of West Virginia, Secretary Mayor, and there are definitely a lot of legislators in the state that are excited about food as medicine as well, which is great because when all three components work perfectly together, things can get done a lot easier than one working by themselves. That being said, there's a lot of good talking points to lean into food as medicine. When if you want to reach out to your local legislator, you know someone within the department that needs to speak about food as medicine. Some great angles of that are the nutrition and health implications of food as medicine. We this coming year, there's going to be a big conversation around insurance for the legislature, specifically PEIA. And I know we're going to be looking at any type of cost savings that we need in the state. And food as medicine could be a potential cost saver for the state. It's a way for people to get good local food into their diet, which we have data showing that reduces A1C and can actually lower prescription costs later on down the road. And speaking of that local food, that's another big hitter for this conversation. I think Dr. Greco informed me about a month ago that with her food as medicine program pharmacy, they had, I think, $360,000 go out in farmer contracts last year. That's huge, especially for our local farmers in the state. That is money that is typically not there and is now being put in their pockets. And we can get the state to come on board with that and actually invest state dollars or direct federal dollars into these farmers' pockets. It's a win-win all around. We're getting healthier people in our state. We're getting local food in people's diets, and we are getting funds into our local producers. It's a triple win around the board. But yeah, I know there's a lot of nervousness about going to the legislature, talking to people. Everybody's in their suit and tie. It's honestly one of the best looking capitals in the country, in my opinion. I might be biased though. Uh, but they put their shoes on one foot at a time, just like we do. And yeah, they want to engage. I promise they very much so want to engage in this. And using these talking points and showing them this data, I think will allow us to get on an avenue that allows the state to invest in food as medicine, and we can be a healthier state. We can be a more robust state. And yeah, just want to thank everybody for coming here. Does anybody have any questions? Kristen did a very good job, so I'm surprised. I'm not surprised there's no questions. She really covered her stuff.
Does anybody have any questions that are not related to Kristen's presentation or just in general? We have about 8 minutes before close. So if you have anything like on top of your mind that you'd want to ask us, please feel free or put it in the chat. Do you want to do that, Kristen? Do you want to talk about, do you have anything else you want to talk about?
I'm muted. I have so many things I can talk about always. I want to show some of the other documents that I mentioned. So this document is West Virginia's quality strategy. And it's kind of wonky to navigate, but I just wanted to send it in case people wanted to just breeze through it. Additionally, I wanted to share the Bureau of Medicaid Services actually has a lot of documents on their website, which is not always the case for state Medicaid agencies. And I'm a little surprised, and I'm actually like quite impressed. So the document that I send is their chapter on managed care. So that can be interesting to look at, just kind of spells out like what the managed care program is in West Virginia. And I'll send the West Virginia BMS website. Here we go. And here is the BMS website that has a lot of additional information, including Medicaid 101, like PowerPoints and stuff like that on there. So it does have some explainers. Some of the documents, even though they're really good at posting them, some of them are from like 2015. So when you're looking at things, just make sure you're looking at the date. And if you can't find a date, then just be a little skeptical on how up to date it actually is.
Great. Thank you, Kristen.
Yeah.
Does anybody want to share like any updates in general about a new program or anything else? We have a few more minutes.
Hey Miranda, it's Bree Cox from
Yes.
Kentucky.
Yeah.
I'm sorry, I maybe was a couple minutes late, but I think you should give the group an update about Boston and some of the things that we saw there if you didn't already. I think that would be really helpful for everyone.
Yeah, I didn't. I can do that, Bree. So yeah, Bree and Nika and I were all in Boston at the third annual Food is Medicine Summit. So every year for the last 3 years, Tufts University, the Food is Medicine Institute, and Kaiser Permanente, along with the Rockefeller Foundation, put on a national summit. And so they actually had 1,000 attend the summit virtually, and there were, I think, about 250 people in person. So it is an invitation only event. So they do try to keep it small. But they had multiple senators who were sharing about food as medicine, really excited to see the momentum nationally that is happening around food as medicine. And so, they actually shared research of programs that were really showing positive health outcomes, decreased lowered costs, decreased ER hospitalization. So just really exciting about all the research that is coming out proving that food as medicine initiatives really do work. And I would say for me, something that I really took away was they were actually talking about food as medicine becoming integrated into healthcare so that, it's standard of care instead of something that we're like doing as the side, but really to make this something that becomes in healthcare and that we're doing it as an initiative to help people. And so it's something you don't have to think about. Like they said, do we think about stopping medication? No, we don't. So this is something that we really need to think. There are some people that are going to need to continue to afford food. That was something that one of the participants had said was that he couldn't afford the food. Like it wasn't an issue of him not knowing what to do with it. He couldn't afford it. And with them giving him the affordability, then it really did change his life. And they actually talked real quick. I'll share a testimony that really impressed me, but there was a woman that was in I think it was liver failure, liver or renal. I can't remember which one now. But she was actually, so they told her, there's nothing we can do for you. And she basically, they were like, you're going to die. And she got into a food as medicine program and ended up completely changing her life. Like she now is off medication, her everything has came back, her labs are normal, and she is actually working in food as medicine. And I thought that is just like a huge story of like the impact of what food as medicine can do. So just really need to hear about that. There's so many stories like that, but really just the difference that it's making. And I think we have to really think about I've been thinking it's a treatment, like this is not us just giving away food. It is actually a treatment and they were talking about that, having the right person for the program. You have to, all of those things, those standards of making sure they're following up, getting their labs, getting the nutrition education, like all of those things, we have to have those really robust programs to see the outcome improvement that we want in food as medicine. So that is my takeaway with that. But I think we're almost out of time, Ryan. So if you want to go to the last slide, I will close us out. So, and actually, for some reason, I'm having trouble seeing the slide today. Here we go. All right. So this was our last meeting. We're going to announce our 2026 meeting schedule before the holidays. In 2026, we will be switching to quarterly meetings. So just look out for that. We do want you to help us get the word out. Please send a registration link to your friends and colleagues. Please share that. We do want to, as much as we can, we want to get many members as we can to really move food as medicine forward. And so please invite people who you think would be really helpful with this work. And then you can also visit our website, www.foodismedicine.org. But we could not do it without all of you. So please help us make a difference in West Virginia and really improve the health of West Virginia. So thank you for being here today. All right. Bye, everyone.
Thanks so much. Bye, everyone.